Hey there, everyone, and welcome to today's lesson on stroke management in the emergency department. So it's really important to know what kind of stroke we're dealing with, and it's usually established in the first 30 to 45 minutes of patients in the emergency department. So the reason this needs to happen quickly is that the treatment that we give to cure one type of stroke can actually kill the other type. So the assessment of these patients begins long before they even get to you. EMS, or emergency medical services, can be a huge help for these patients. If a stroke is suspected in the field, many EMS agencies, especially in America, can actually call ahead to the ED to let us know what's about to arrive. Now, when we get the call, some hospitals will actually activate their stroke team prior to arrival so they can receive the patient at the door. I would check with your facilities about its protocols in relation to stroke response. Now, keep in mind, I use the term code stroke because that's what I'm used to. That's what a lot of the facilities I've been in use. But the activation of the stroke or neuro team can have different names. I've heard code silver, code neuro. Just know the specific term is not important. It's the fact that we're getting the proper people to the bedside as fast as possible. Now, when it comes to that early identification of a possible stroke, we like to use the FAST mnemonic. F is for facial droop. Is one side of the face drooping down? Is there asymmetry to the muscles in the face? If they stick their tongue out, does it go to one side? A is for arm drift, and we have them hold both arms straight out in front of them, and we watch to see if one slowly lowers. That's usually indicative of some sort of neurogenic issue, and we call that contralateral weakness, that one-sided weakness. S is for speech problems. Are they slurring their words? Are they having trouble getting their words out? Are they not making any sense with what they're saying? Are they having some expressive aphasia? All of these are red flags. T is for time. We need to know when the symptoms started. The saying time is tissue comes into play as the longer we wait, the less chance of recovery there really is. This is vitally important in the cases of ischemic stroke, as there is a window in which we can give our clot-busting agent. So we need to know the patient's baseline. What's his normal? If he normally slurs his words, we can't trust that as a symptom. This may be someone who, has had a previous stroke or has some sort of speech impediment. If they're showing that one-sided weakness, we need to know if this is new or chronic. We also want to know if they have any comorbidities that could be manifesting as stroke symptoms. Things like hypoglycemia, a raging active UTI, or things like a brain tumor or hydrocephalus. All of these can mimic stroke symptoms. Again, we need to know when the patient's symptoms began, like to the minute if possible. Saying, it started this morning, well, that's not good enough. We need to know what time. The window for TPA closes quickly. So if there's a big difference if they were seen last normal 3 hours ago as opposed to 6 hours ago. So one of the standards of stroke assessment is the NIH stroke scale. I'm sure you've all heard of this. It's used across America as a tool to determine the severity of symptoms for our stroke patient. It's a series of measurements that each have a score. It tests 13 items, such as level of consciousness, eyes, facial muscles, motor and sensory function, and speech and orientation. Each category is graded, and the total score can range from 0 to 42. 42 being the highest score and probably completely alert and oriented, and 0 being probably dead. Yeah. The actual sheets, the NIH stroke scale sheets contain pictures to identify specific items, such as like a key. All right, that's a key. Or a glove. That is a terrible glove. And if you asked a guy to identify that, they probably wouldn't be able to. But find the sheets and you'll see it. There's also another picture that asks the patient to identify what's happening. It also contains a series of phrases for the patient to repeat, words like tip top and several others, and also a series of words to remember and repeat back. So you can view the entire NIH stroke scale assessment by clicking on the link within the lesson page here. Now, while we can suspect a stroke from the way the patient is presenting, there are some other conditions, like we just talked about, that mimic a stroke presentation. Hypoglycemia can cause disorientation and slurred speech. And how do we check for that? Simple. We do a finger stick. A UTI can absolutely cause changes in level of consciousness as well as like a complete change in mental status. Just think of any of our elderly patients that have come in confused. Many of them have UTIs as well. The list of metabolic disorders that can cause changes is way too long to list here, but things like hyponatremia, hypercalcemia, sepsis, even something like a bad case of the flu, they can all manifest symptoms that we could mistake for a stroke. So after a CT scan, we're going to need to make sure we rule out or treat as many of the conditions as we can before moving on. Now, that being said, check your facility. You need to know the protocols. Some facilities want us to do that finger stick before CT. Some want us to get blood work before CT. Check with your facility to know specifically the kind of order of events during your stroke code situations. So in the treatment of stroke, there are what is known as timeline goals. These are specific metrics that every ED is supposed to meet in relation to the treatment of an acute stroke. The door-to-doc time, meaning the time that a patient arrives until they're evaluated by a doc. And this doesn't have to be neuro. It can be the ED doc. The door-to-doc time is 10 minutes. The door-to-stroke team notification, when you got to let the neuro guys know, that is 15 minutes. Door-to-CT scan, when they are in the CT scanner, not when they're going, but when they're in the CT scanner, that is the 30-minute mark. When that CT is read is 45 minutes. And when we are able to give TPA, should be no more than 60 minutes. Now, again, I will say that time is tissue. That being said, some facilities will adjust these times for their own purposes, sometimes decreasing the times allowed. Again, always check with your guys and your facilities on their actual stroke protocols. Now, the moment we've all been waiting for, treating our stroke. So if we determine the patient is having an ischemic stroke, that blockage, meaning the CT has shown a blockage that we believe we can clear, it is time to mix up some clot buster. This is also known as TPA, or tissue plasminogen activator. Trade name is commonly Activase or Alteplase. We see it here. It usually comes in a box with two vials. One is the powder that we reconstitute, and the other is the liquid to reconstitute. It also comes with a spike to connect the two. Now, once the dosage is mixed, it is calculated as 0.9 milligrams per kilogram, and it's not to exceed 90 milligrams over the total infused 60 minutes. So 10% of the dose is given as a bolus, and the remaining 90% is given over 60-minute infusion. Check with your people, but everywhere I've worked, as the TPA is infusing, patient is under a one-to-one nursing care, one nurse, one patient. So if the TPA is ineffective or the neurosurgeons think it's going to be ineffective, they can do a percutaneous thrombectomy. This is basically threading a catheter through the vessel. So here's our vessel. Here's our clot. It's wonderful. Wow, that's a big clot going through the vein. So they basically thread a catheter through the vessel with a kind of grabby thing on the end. I'm not sure the correct term, but just think of those claw machines at the arcade. They're going to thread this up to the clot. They're going to grab the clot with the claw thing and pull it out. And everyone gets a teddy bear. Okay, that last part isn't true, but they do remove the clot manually. It's actually a really cool thing to watch. Google it, and you can find some pretty cool videos. If the stroke is hemorrhagic, the primary concern is basically to prevent increasing ICP or intracranial pressure and stop the bleeding. If it's not too severe, neuro may be able to just do a ventriculostomy, drilling some holes in the skull and placing that EVD or extraventricular drain and allow for some gradual drainage. But if it's more severe, they may require a craniotomy to kind of remove a piece of the skull and allow for more immediate drainage and decompression. Some concepts to remember, guys. We always need to be aware of proper intracranial pressure and maintaining intracranial regulation. If you want to know what the proper pressures are and a little bit more about intracranial pressure and proper regulation, check out the MedSurg Neuro units here on nrsng.com. A hemorrhagic stroke is really going to affect this and increase those pressures. Now, with our ischemic strokes, perfusion is decreasing by the minute, and it needs to be corrected in order to save brain tissue. We need to clear out that clot. And as we've said a few times, time is tissue. Follow the metrics on the door to whatever times, and that's in order to treat our patients safely and effectively, but quickly. Code stroke, code silver, whatever you call it, guys. If you see the symptoms, call the stroke team. We can't say it enough. Time is tissue. Try to get that time of onset, document it, remember it. Be aware of your timeline goals. These are the limits. Doesn't mean we can't move faster. Treatment, of course, will depend on the type of stroke the patient is having. And once we determine what type of stroke we're dealing with, be ready to administer TPA or assist neuro with any procedures they might do in the ED or getting them up to the OR. All right, guys. So that's our lesson on stroke management in the emergency department. Thank you all for watching. Check out some of our other emergency medicine lessons here on NRSNG. And as always, happy nursing.